Welcome to HeartBrothers webinar on hypertrophic cardiomyopathy. We're honored today to have a phenomenal subject matter expert, Dr. Maron of Lahey Clinic. He's going to be our featured speaker. My name is Hamid Madavi. I'm a volunteer for HeartBrothers organization. And again, welcome you to our third webinar this spring in our webinar series. Just a little bit of information and some couple notes. Who we are. At HeartBrothers, we're patients just like you traveling the heart failure journey. After a transplant, we've decided to give back to the heart failure community. Our mission is to support heart failure patients and their loved ones to navigate a life with heart failure and all its challenges. I wanted to thank our sponsors through their year with their generosity. They allow us to offer this and similar programs to the heart failure and transplant community. Thank you to TransMedics, CareDx, Cytokinetics, Abbott, and Novartis. And just here's a quick rundown of our calendar for the year. We have monthly virtual patient support groups the second Thursday of every month at 6 p.m. We have 8 webinars focused on heart failure, different aspects of it. This is the third one in the series. The next one is going to be on May 19th, the heart failure and transplant journey, the caregiver perspective. This is going to be a really neat webinar where we're going to hear from not the patients, but the people who take care of them, their spouses, their loved ones, their significant others who travel this journey with them. And we're going to hear their point of view and their perspective. On August 1st, we're going to have our 6th annual Mike Guster Memorial Golf Classic. On September 23rd, we're going to have Friendly Feud 2. This is a great event where we all come together and have a gala in Newton, Massachusetts, and we see the local hospitals and transplant centers in the area compete for bragging rights, and that's a lot of fun. October 2nd through the 10th, we have our 3rd annual Member for a Day golf auction, where you can bid on golf courses that normally are not open to the public. Some of them are pretty exclusive, and you and your friends can bid on a foursome to go and play there. And then December 1st and 2nd, we have our 8th annual Team HeartBrothers Symposium, where we as HeartBrothers, we come together and review the year, and we discuss about what we're going to do in the year to come. Just a quick disclaimer, just today's participating medical professionals are licensed and qualified to practice medicine. You should always seek the advice of your own physicians or medical team with any questions you may have regarding your specific medical condition. The information shared today is not intended or implied to be a substitute for professional medical advice from your own healthcare provider. So a couple quick items on virtual meeting best practices for higher quality viewing. Choose full screen in the upper right corner. To make comments, utilize chat in the bottom navigate section, then select all panelists and attendees from the drop-down. To ask questions, utilize the Q&A in the bottom navigation panel. So we'll do a detailed introduction, but it's my distinct pleasure for today to feature Dr. Maron. For our moderator today, we're going to have Linda Ordway. She's a master's of nursing, and she's a nurse practitioner extraordinaire from Tufts Medical Center. Our panelists are Tom Bull, Karen Klimczak, Darlene Goodwin, and Tim Goodwin. All are patients that have hypertrophic cardiomyopathy. 3 of them have been transplanted, and Tim has not been transplanted. We will come back to the question and answers. And now with this, I'm going to turn it over to Linda. Stop sharing my screen, and Linda will take this and start the moderation.
Thank you, Hamid, and thank you for inviting me to moderate this amazing setup for today, this webinar. And welcome everybody to this webinar on hypertrophic cardiomyopathy, or HCM. As you can see, we have an amazing lineup for you to learn from the absolute experts on this topic. What I want to start with, a very extremely basic overview and a few points about HCM. Hypertrophic cardiomyopathy, or HCM, is relatively common, often genetic, heart muscle disease, where the heart muscle wall becomes abnormally thick, which can make it harder for the heart to pump blood. HCM affects people of all ages, races, ethnic groups, and both genders. It is now a treatable disease that is compatible with normal life expectancy. That's the good news. One or more of the invasive treatments is heart transplant when a patient's symptom doesn't respond to medication. And through this webinar today, we'll talk about some of these points. It is now my pleasure to introduce our esteemed speaker, Dr. Marty Maron. Dr. Marty Maron is an internationally recognized expert and leader in HCM. He is currently the medical director of the newly launched Hypertrophic Cardiomyopathy Center at Lahey Hospital and Medical Center, just north of Boston, and was for 20 years the medical director of the highly regarded Tufts Medical Center HCM program that he developed from his inception. And I've had the pleasure of working with Dr. Maron over a number of years. He has an interest and expertise in virtually all aspects of HCM and is responsible for defining both MRI imaging in the disease and novel drug therapies for the disease, presently as the principal investigator of the new, I'm going to need some help on the pronouncement of this, alpha-camtin, is that how you say that? Myosin inhibitor initiative. He has been a prolific clinical investigator, redefining HCM as a treatable disease that is now compatible with normal longevity, and has published more than 250 peer-reviewed papers in the New England Journal of Medicine, Lancet, Circulation, and the Journal of the American College of Cardiology. Also, he was recognized as HCM Physician of the Year in 2011 by the Hypertrophic Cardiomyopathy Association, the national patient organization, and has been named a top doctor by Boston Magazine yearly since 2017. Thank you, Dr. Maron, and I look forward to your presentation.
Great. Thanks, Linda. Appreciate that. That was really very nice welcome and introduction. I appreciate that very much. And it's an honor to participate. I mean, I've been a fan of the Heart Brothers organization for a long time, and the incredible work that they've been doing for heart transplant patients. It's amazing, patient-centric group, and really providing an enormous benefit to this patient population. And it's an honor to have the opportunity to help in my way by giving a little bit of an overview. It's going to be very brief and I hope simple so that everybody can understand about hypertrophic cardiomyopathy. Linda did a great job of providing some bullet points. I'm going to dive down just a little bit deeper in a little bit more detail. And I'm going to do that with just a couple slides just to make it easy. These are simple slides, nothing complicated. Okay, I hope everybody can see that. Let's get started here. Okay. Oh. Okay, good. As Linda was saying, I'm the director for the Hypertrophic Cardiomyopathy Center at Lahey Medical Center in Burlington. I was for 20 years at Tufts, and I've been involved in HCM for a long time, over 25 years now. And as Linda was saying, kind of all different aspects of HCM, but particularly involved in treatment of the disease for patients and family members. And so what we're going to do here, if I can get this up, get this to work. Okay, let's start first with just a picture of what hypertrophic cardiomyopathy, HCM, looks like. It's a heart muscle disease. It's a genetic heart disease. So these is a disease caused by a genetic mutation. We'll talk about that in just a minute. But this is an image that shows you what a heart with HCM looks like compared to normal. Normal hearts are 4 chambers, 2 bottom and 2 top. And those chambers are bright here, and the heart muscle is dark here, dividing the 2 bottom chambers. The left is obviously what normal looks like, and to the right of it, or next to it, is what a heart with HCM looks like. You can see that an HCM heart, as we mentioned, is thicker, the heart muscle, than normal. And you can appreciate that really well here. Very thick heart muscle throughout the entire left lower chamber of the heart. And that's important because what happens there is that starts to do 2 things relative to normal. It decreases the cavity size, the amount of blood flow that can come into the left lower chamber, and therefore can sometimes impact the amount of blood going out of the body. It's just not enough space because the heart muscle is thicker. And the heart muscle is also, because it's thicker, it's not as able to relax as well to fill with blood. Okay? So we got problems with relaxation and the size. So those are 2 aspects that are kind of working against patients in terms of the efficiency of the heart in patients with HCM. This is just to show you kind of what a real heart with HCM looks like. This is an explanted heart taken out of a patient who underwent heart transplant. And just to show you, again, the ruler here is the thick heart muscle. Normally it's less than 1 centimeter in thickness. This is 2 centimeters, so it's twice as thick as normal. And again, because it's so thick, it really decreases the cavity size here of the left lower chamber, decreasing the amount of blood flow coming in and out. So it makes, again, for a really inefficient pump. And because it's so thick, it doesn't relax as well as it should during the relaxation phase. And therefore, you're not filling with enough blood either. Okay? Those 2, again, those 2 are the 2 major issues kind of working against patients with HCM in terms of heart efficiency. And those ultimately lead to symptoms. We'll talk about that in a second. HCM is very common. Actually, it's our most common genetic heart disease. 1 in 500 with HCM in the world, irrespective of almost any geographic area. So we see HCM on almost every country in the world, 90% of the world's population. And with a prevalence of 1 in 500, you're talking about 600,000 to 700,000 people in the United States with HCM. So it's relatively common if you think of it in those terms. Okay. It is, as Linda was saying, similar in prevalence among gender. So women and men, same prevalence for the disease as well. And again, there's no racial or ethnic similar between the race and ethnicity as well. So those making it a very common heart disease. Okay, now I want to make this point too, because it's important as well. And that's this, that HCM, because it's so common, it's actually more common than many other diseases that are thought of as more common because perhaps they have different kinds of visibility behind them, things like cystic fibrosis and multiple sclerosis and even other cardiac diseases as well. But in reality, as you can see here, HCM, affects a lot more patients overall than these other diseases that, again, are often perceived to be by the general public as more common. And again, just this point about 1 in 500 anywhere in the world, if the United States, that's about 600,000 people that are affected with HCM. And it's a genetic heart disease. And that means that this is just a figure just showing you, it's a complicated figure, but it's actually just really simple. This is actually showing you what's called the sarcomere. It's just the structure of the heart. It's what the heart is actually made of at the basic level, sarcomeres. These are proteins. And so the mutations that cause HCM, that cause the heart to become thicker, are mutations that involve the actual structural apparatus of the heart, the sarcomere. Different mutations in different areas and different locations. And so for this disease, it's a genetic heart disease. And so nothing that a patient did or didn't do or took or didn't take had anything to do with them developing HCM. It's because of the mutation. The mutation causes the disease. The results in the muscle becoming thicker. And this is a disease that's autosomal dominant. It means that there's a 50% chance that an affected patient can pass that mutation down to a child. So a 50% chance the next generation a child in the next generation can have that same mutation and potentially develop HCM as well. So you're born here with a mutation in the sarcomere, the structural apparatus of the heart. And typically that mutation gets turned on. The thickness that I showed you develops during puberty for reasons that remain a little unclear. There's something about adolescence, the growth period, that causes the muscle of the heart to then become thicker in a patient that has one or more of those mutations. And therefore, when that occurs, it's at that point that a patient can be at risk of developing symptoms. And those symptoms can develop at any point in time the rest of a patient's life. And obviously can occur over many decades of risk period, living with a genetic heart disease that occurs so early in a patient's life. Why are we here, really today talking about this disease? It's the most common genetic heart disease. Again, it's transmitted in an autosomal dominant manner, which just means that there's a 50% chance that the next generation of an affected patient can also receive that disease-causing mutation. It's got a lot of heterogeneity in how these hearts, the degree of the thickness and what can happen to patients, but it remains today the most common cause of sudden cardiac death in young people and a major cause of heart failure at any age, as I just showed you. There's two forms of HCM called obstructive and non-obstructive. We'll touch on that in a minute, but most common cause of sudden death in young people and a major cause of heart failure at any age. Those are the two important issues related to this disease, HCM. Patients can develop symptoms, which are very similar to other symptoms in other heart diseases, including other heart diseases that cause heart failure, shortness of breath, chest pain, palpitations, fatigue, lightheadedness. Those are the most common symptoms. And we spent a lot of time putting patients with HCM into two kind of categories, two different types of disease. There's the obstructive form, obstructive HCM, and then there's the non-obstructive form. Obstructive just means that blood flow can be obstructed going out of the heart in those patients, and that's not present in the non-obstructive patients. And we're going to focus just today, we're focusing today on the non-obstructive patients because those are the ones that can develop the most severe heart failure and need heart transplant as a result of that. Obstructive HCM can also develop symptoms, but they have also different treatments like surgery and catheter-based treatments that can help improve how they feel dramatically with this form. So if you've got obstructive HCM, you've got a lot of treatment options that can help you feel better that do not include heart transplant. Where in the non-obstructive, no blood flow being obstructed going out with HCM, we've got a few drugs, but the reality is that unfortunately we don't have a lot of drugs or other therapies, and really the definitive treatment for a patient that becomes really symptomatic with heart failure and who has non-obstructive HCM is today still heart transplant. And the reason that patients with non-obstructive HCM develop heart failure and need heart transplant is the reasons that I showed you at the beginning. That thick heart muscle doesn't relax well. There's issues of distensibility. And so it's like a stiff balloon. If it doesn't relax, It doesn't fill well with blood. That cavity is already small because the muscle is thick. And so what that causes is increased heart pressures and a decrease in kind of heart pump function, or at least the amount of blood going out of the heart. So these are the two major issues that cause left ventricular, left lower chamber relaxation problems and left lower chamber distensibility problems that cause that pressure to be high and ultimately heart failure to develop. And so we'll finish by just saying, who do we consider for heart transplant in non-obstructive HCM? It's a significant decrease in how patients feel day to day and how they function, objectively, how much exertional capacity is diminished because of their non-obstructive HCM. And we have different ways of measuring the severity to which a patient feels poorly from heart failure and how poorly they are functioning because of heart failure, including objective tests like cardiopulmonary exercise tests and catheter-based measurements to get a better sense of pressures in the heart. So how patients feel and how they function and how that decreases or diminishes despite medicines is kind of how we then move on to considering a patient for heart transplant. I'll mention that as well, that in this disease, unfortunately, many patients are not candidates for some of the other therapies that are available for heart transplant patients, like left ventricular assist devices, because those devices just anatomically don't work in this thick heart. It's just not a big enough heart cavity size for those assist devices to really work well. And so patients really, if they fail drugs, then have to really move on to heart transplant listing. And I'll just say to conclude that over the last 20 years, we have really felt that with the therapies that have come along and that are continuing to emerge for this disease, that we feel that in expert HCM centers, that most, if not almost all patients, we do whatever we can to get them to the finish line with both a good quality of life and normal longevity. And that includes, of course, in a small number, considering heart transplant, but that's a very effective therapy for those patients today. And we do believe that we can get excellent outcomes in almost all patients with this disease today using an HCM expert center and multidisciplinary approach using other expert cardiologists like heart failure transplant doctors when needed. And I'll just conclude by saying that that's pretty true. If you look at the current annual and 5-year mortality rates in patients with this disease today who are treated at expert centers with the current contemporary cardiovascular treatments, including, of course, advanced heart failure treatments like transplant, HCM annual and 5-year mortality rates are much lower than many other cardiac or non-cardiac diseases, including non-HCM congestive heart failure, prognosis following myocardial infarction, et cetera. And so including many other cancers as well. And so it brings home the point again, it's a highly treatable disease today where we do everything we can with the current therapies to provide almost all patients excellent quality of life and normal longevity. So I'll stop there. And again, I'll just stop there. And again, I'm happy to answer questions at the end as well. And I appreciate the opportunity to give you guys a little bit of an overview on this really important genetic heart disease, HCM. Thank you.
Thank you, Dr. Maron. That was an amazing overview to help everybody in the audience really understand the basics of what it is and, the different types and, where you go with treatment in this. And we have a number of questions that were coming through. I just want to remind people we will tackle questions. I've taken them down, and I will pose your questions to Dr. Maron during the Q&A. So we'd like to continue on here, and it is now my honor to formally introduce our panelists for today. Hamid previously mentioned their names, but again, I'm going to introduce. It is my pleasure to introduce Darlene and Tim Goodwin, mother and son, as well as Karen Klimczak and Tom Bull, who are our panelists today, and are really going to give us the perspective of what it's like to actually be somebody living with HCM and going through these treatments that Dr. Maron outlined. So how we're going to run this session is that I'm going to pose some questions to our panelists, and really, but this is all about them telling us their story and what they feel is important for us as the audience to understand what it's like to live and be treated with HCM. So we can start, whoever would like to start first, but if one of you would step forward to be the first person and I'll have each of you tell us if you could talk about your journey with HCM, really kind of starting from when you first realized you had a heart problem, how you came to be diagnosed with HCM, and then the treatments that you went through. And we'll all talk a little bit on the end as far as how life changed for you one way or the other from before to after you were treated for your HCM.
I can go.
Thank you, Darlene.
Okay, so I always knew that we had a family that was filled with, we called it idiopathic hypertrophic cardiomyopathy stenosis. But we always knew that it was in the family. Many family members have passed away. My father had 5 siblings, and 4 of the 5 passed away, except, well, my father was the only one that had the option of heart transplant. The others all had obstructive. Fortunately, I always thought fortunately, but the way Dr. Maron spoke, it wasn't so fortunate. But to me, it's we have more longevity because everyone else had died before they were 30. They had many surgeries, the myomectomy or whatever you call it, and many different drug therapies. But that was years ago. It's probably not as good as the ones that we have currently. I did not have a diagnosis for myself until I was 24, pregnant with my 3rd child. I had one of my cousin's doctors in Lewiston, Maine, had offered to give us all electrocardiograms to let us know if we had HCM. Obviously, we all know that that's not how we diagnose HCM, but I thought I was in the clear, and I just knew I always had this thing where my head would feel like it was going to blow up. And I just thought that was just my thing. I didn't put 2 and 2 together that it was heart disease. So after I was pregnant with my 3rd child, we stopped having children. And later on in life, we waited until I lived fine, normal, just like I always had, not very symptomatic, other than I had this thing where I would be really short of breath every now and then. And we continued ballroom dancing. We did all kinds of things. And we ballroom danced like 3 times a week, and then a 4th time just to go out. So we had lessons, and, I worked full time. And I had thought to myself, boy, if I have HCM, someday I may need to get disability, so I should work. Our family had just been, they're all up to 17, 18 years old by now. And so I decided to start working full time, and I was able to work full time until I got really sick. And by getting really sick, I started having cardiac asthma, and there was a lot of passing out, hard to breathe in ambulances. And I finally agreed to have a defibrillator. And when I had my defibrillator operation and my ablation, it was decided it was time to go on the transplant list. Is there anything else you want to know?
No, that's great. Thank you, Darlene. We'll go to another panelist and then we can circle back around if there's something else that you'd like to share. So it sounds like for your situation anyway, you had family members, so you had an inkling about this, and but unfortunately, I can't quite remember if Dr. Maron covered this in his section, but how HCM is typically diagnosed. You mentioned that you had an EKG and that didn't show anything, and clearly that's not the diagnostic tool of choice for HCM. Karen or Tom or Tim would like to?
Sure.
Karen,
I'll go
thank you.
next if you like. Sure. Yeah. Hi. Thanks so much for having me. We didn't have any family history of HCM or heart problems in our family. And in fact, I grew up as a very active child, playing a lot of tennis out in the heat, multiple times per week, played in tournaments, hiked, ran, lifted weights. So it wasn't until I was about 23, and Dr. Maron kind of hit on that, 20s, teenagers, one of those times of hormonal development, that I started passing out at times when I'd be active. So I'd go out for a run, and 5 minutes later, I'd find myself on the ground, and I was told I had seizures. There was more than one episode of this. And at first I just thought, maybe this is just me pushing myself. In your 20s, you're pretty invincible. So I also thought, maybe I'm just working too hard, keeping long hours, maybe, I don't know, just all those things that you think, it couldn't be anything other than maybe something that I'm doing. And but this would happen a little more often than one would imagine. Like, it happened at my best friend's wedding, where I passed out and I had to run to the priest's little back office pew and pass out. And it would happen when, again, like when I go for walks. I started a new career and I was going to school for that. And I was just going up a short hill after a little bit of a drive. And, I find myself on the ground and an ambulance coming, and not really able to figure out what's going on. So after a few of those sessions, especially at the school, I'd had enough and, just had to pursue this more. So I live in Connecticut, and I was able to get in to see some local docs, electrophysiologists, and they thought initially that I had something called neurally mediated syncope. And so I went on that, went with that for a while. We tried a number of medications to help my blood pressure, pretty much. And from there, did echoes, did EKGs, found that things didn't look exactly right, but they didn't look too abnormal. I wasn't obstructed. So long story short, I went through and saw a battery of different kind of cardiologists, specialists, endocrinologists, and neurologists. I had gotten many concussions from these falls. At one point, it was even recommended that I see a psychiatrist, which definitely wasn't the case of what I needed at that point. It wasn't for about 3 to 4 years. So until I was 27, after seeing all these doctors and not knowing, should I keep running? Should I keep active? I did, because again, I'm in my 20s and I want to live my life. But, had a number of concussions and passing out sessions. And finally, an MRI was ordered for me, and it was determined that there was some thickening in my left ventricle. And the name of Barry Maron was actually mentioned to me as somebody that has done quite a bit of research on this topic and athletes. So long story short, I called Barry's office out in Minneapolis. At the time, he was out in Minneapolis. Unfortunately, I didn't know of Dr. Marty Maron here right in Boston, but did get connected with him eventually. And within one visit at the Center of Excellence, it was determined, they did a battery of tests in a number of, 2 days, a day and a half. And right away, he knew that I had HCM. And because of all of these episodes, the syncopal episodes, the lowering of blood pressure when I was becoming active, obviously I couldn't continue this way. And so it was recommended that I get an ICD, which I also had implanted there a few days before Christmas. And that's honestly really saved me. And going to the Center of Excellence was the absolute best decision. And getting hooked in with Barry and then later Marty Maron absolutely was a lifesaver, because how I see myself when I had HCM was living my life and having HCM. So having that, having a team there, a very supportive team of specialists who has seen many others that have had these symptoms that have been in my same shoes. It was very, very helpful. I was able to, like I said, be completely supported, continue being active. So I did continue to run in a very safe way. I continued to do activities. I continued to work full time, move out to Chicago for a number of years, travel internationally, do all the things I really wanted to do. Yes, I had an ICD, but I was in great hands. And whenever something would come up, I would check in with my cardiologist, and I would go for many routine visits and stay on the path, and did need some medications as well. So this continued for a number of years. Now I had the unobstructed type of HCM as well that Dr. Marty had mentioned. And eventually it came to the point where my symptoms were becoming too much. So I was at a high stress job. I was traveling a lot, but something was changing in my heart. So long story short, I started seeing Dr. Marty Maron out in Boston. And at the time I was living in Chicago. So I'd fly back to see my family who's in Connecticut, and we would have meetings around the holidays, and he's followed me so closely. And his entire team, Noreen, his entire team was incredibly supportive. So whenever something would come up, like I said, I would contact them, and eventually he helped me realize, and it was very apparent that I was in heart failure and I would need to go to the next step. So I was in heart failure for a number of years. I changed my lifestyle. I moved closer to Boston. I moved to Connecticut. And I was actually, one hope that I had, again, like I said, I really feel like I was living my life and had HCM, was to have a child. And we were able to safely do that, even though I was in heart failure. It was many years of planned out. It wasn't like a spur of the moment. But now I have a 5-year-old daughter, my husband and I, and eventually, like I said, things were just getting to the point, even after, and especially after having her, where I did have a few more syncopal episodes. And I was having, I have like ventricular arrhythmias, and it got to the point where my functionality of my heart, as well as how I was feeling, just became too compromised. So we did, based on the tests that Dr. Maron's team had run, it was determined that I should meet with the transplant team, and then was listed shortly afterward. So I'd say from there, I was on the list for about a year and was watched very closely, and was actually called from home New Year's Eve of 2020. And here I am now. So it's been a little over 15, 16 months, and I couldn't be more grateful. One thing I just want to point out too, and I hope I'm not taking up too much time, but is that throughout this whole process, being at the Center of Excellence at Tufts, and under this care, which would then translate to Lahey Clinic, I was really supported and able to live a completely full life, having HCM. And then with the transplant team too, I felt completely supported. And when I got to the point of transplant, I feel like the team had done such a good job to keep me so well and to be able to live the life I wanted to, that coming out of transplant, I would say, although it's a roller coaster, I just feel so grateful because I am so healthy. I was able to recover really well, and still am recovering, but I was so healthy going in that's translated to a great outcome as well. So thank you so much for having me. I really appreciate the opportunity.
Thank you, Karen. Thank you for sharing all of that. What a great inspirational story, and to hear everybody's story has similarities and differences. And I think we all learn so much from every one of your, each one individually, your experiences. So thank you. Tom, could you, I'm gonna kind of save the best for last, Tim, and maybe have Tom speak, because Tom is also, has gone through with a transplant, and we know that you haven't, so maybe you can shed something different for us. So Tom, if you would be willing to share your story.
Sure, absolutely. Thank you for having me. And first, I'd really like to thank Dr. Maron and his whole team for literally saving my life. I've never actually, Marty and I have never interacted directly, but I worked with Ethan Rowan from his office very closely, and Noreen, and they literally saved my life. I first found out that I had a heart issue when I was quite young. My little brother was born in 1977, and shortly after birth was diagnosed with a hole in the heart and referred to Maine pediatric cardiology. Then he was diagnosed with IHSS, and at the age of 4, he had to travel out to Minnesota. I think they were the only ones that were really working on peds at that time for a myectomy, where they cut a pie-shaped wedge muscle out of the interior of his heart. And because of his ongoing condition, they started to monitor me. They started to keep a close eye on me. I was a very active kid. I played sports. I played soccer. I was the goalie. I'm 6'5", so you take the big kid and put him in the goal. I was also the center in basketball. When I turned, I guess I was 15 or 16 years old, as Dr. Maron said, a lot of this manifests during puberty, especially for males. And when I was 15 or 16 years old, they came, and the cardiologist team came to me and said that I could no longer play sports. They wanted to remove the adrenaline factor. And I was largely asymptomatic, but they were being just ultra cautious. And then when I turned 19, I was going to school out in West Virginia, and I came out of the house one day. I'd been studying all night, and I had a syncopal episode. And they took me to the hospital in Wheeling. And, obviously with my history, they said they wanted to keep me overnight for observation. And in the morning, the doctor came in and said, "Mr. Bull, I'm shipping you to Pittsburgh for further testing." That was the closest heart center. This is 1990. And I said, "Well, what's going on? Can you tell me? I've been researching, dealing with this my whole life. I understand terminology. I understand all of it, anatomy, physiology. Tell me what's going on." And he looked me right in the eye and said, "Honestly, I don't know." He said, "You threw a bunch of rhythms in the middle of the night. We don't know what they were, but I want you to go be evaluated." So I went to Pittsburgh. They did an EP study. That was back in the days where it was like a big whiteboard on the wall, and they were drawing out the pathways, marking out the pathways on the wall of the EP room. And they determined that I needed an ablation. They gave me an ablation, and they also implanted a defibrillator at that time, 1990. It was the size of an old tape Walkman, and it lived in my abdomen. The thing was huge. And I think the battery life on it was about a year, maybe 2 years. And I went through several iterations of that. I probably went through 8 or 9 devices in my history, and was largely asymptomatic. I really didn't even take any meds until 2016. My defibrillator, I had a broken lead, and the defibrillator fired continuously for a while. And they wound up shutting it off. I had to wear the Zoll vests for a while until we could replace the lead. But it seems, pretty much from that point on, I started to go downhill. And I was diagnosed. I finally wound up. Maine we tried every single drug that there was, and they, finally just said, "You need to go to Boston. You can either go to Tufts or you can go to Brigham." And I had read a lot of Dr. Maron's papers, just trying to understand my own disease through the years, and decided to go to Tufts. That's where I wound up seeing Dr. Ethan Rowan. And he handed me a paper that he wrote. After all these doctors throughout the years had looked at me and tried every drug possible, he handed me a paper, and it was like he had been following me around my entire life. And he said simply that this is not going to be an easy journey. I was non-obstructive HCM, and I was left ventricle preserved. So my ejection fractions were exemplary, essentially. They were really good. Shortly thereafter, I was listed, and I lived at Pratt 8 for 9 months, waiting for a heart with a Swan catheter the entire time. And shortly after Thanksgiving of 2018, I received a heart. I received the gift of a heart. So it's been 3 years. It's been an amazing, amazing recovery. Life is so much better and so different than it was before. I couldn't even carry a basket of laundry halfway up flight of stairs. And now I said to my wife the other day, I said, it's like I'm a machine. I get on the beach. I live in Old Orchard Beach, Maine, and I get on the beach and I just start walking. I'll do 3 to 5 miles easy without even thinking about it. And that never would have been a reality pre-transplant. And I just feel like I'm the luckiest guy in the world. You know, people win the lottery. Good for you. I'm alive. You know, it's a whole new world for me, and I'm so grateful.
Thank you, Tom. Thank you for sharing that story again, which is compelling in how you're, even when you know historically, when things start to go awry. And it sounds like one thing about knowing early is that you can do some research and learn, you know, where to go. You can decide, you know, what team seems to fit well for you. So I imagine there's something to be said for that, for being able to be prepared and being able to do that. And thank you for also, you know, telling the audience like what life is like afterwards. We were going to wait for that to the end, but I think it's important.
Sorry.
Both you and Karen, no, that's perfect. You and Karen both have mentioned how different life is, and that life is, you know, much more back to normal. And you've painted that picture for everybody. So thank you. Tim,
If I could add just
sure.
one other thing too,
Sure.
just quickly on the hereditary aspect of it. It's absolutely hereditary and rampant throughout my entire family. I have my brother has HCM. My father, it's from my father's side. Neither of my aunts have HCM, but 2 of their children do, and there are 3 or 4 defibrillators in the family at this point. And I did the genetic research in advance. You know, the doc kind of looked at me and said, I don't understand why you want to do these genetics. There's nothing I can do for you. You're a 46-year-old man, you know. And I said, it's not about me. It's about the younger kids. And I was an MYH7 variant. Anyway, but yeah, it's rampant throughout the entire family. It's definitely hereditary.
Yeah, I think you bring up, you know, some really important points, and that's one of the things that I, you know, wanted Tim to be able to kind of expand on a little bit. What it's like, you know, clearly you've known from a long time, given your mom's history and the fact that you've watched your mom go through this and go through a transplant, and heard about things on the other side of that, and what that feels like or means for you, what life is like for you, how those things kind of impact, you know, your decisions that you make now and the things that you do.
Yeah, it's kind of been hanging over my head my whole life. Watching my grandfather get a heart transplant, watching my mom get a heart transplant. There's kind of a degree of anxiety from that. Like, you just kind of have this, I don't know, timer that's waiting for you. I'm not really looking forward to becoming symptomatic, but I'm happy that right now I'm not terribly symptomatic. Part of me is wondering if it does kind of lose some strength as it's passed down, but I've never really read anything to support that. I just know that my grandfather was symptomatic at a younger age. My mother was symptomatic at a younger age, and now I'm 40 this year, and I'm not quite as bad off as they were, which I'm really happy about. I definitely have the arrhythmias though. My doctor is an electrophysiologist. I had a normal cardiologist, but they recommended me to him because that's really my only issue, is I get the arrhythmias, and it's just random, you know, after lunch here and there, a couple of times a week, and I'll feel lightheaded because obviously my heart's not pumping blood effectively. And I like how he explained it to me. It's because of the scar tissue. The inner septum there is not really effectively producing electrical signals because there's a buildup of thickened heart tissue there. So what can you do other than listen to your body and see if it's going to get worse? I still haven't passed out, so I'm happy about that. I hear everyone else's story, and they've all had syncopal episodes leading up to, you know, increased symptoms. But I know it's there, you know. It's just like breathing, you know. You don't think about breathing until you have trouble breathing. You don't think about your heart until your heart starts beating weird, and then all of a sudden you're like, hey, you know, what are you doing there? So I'm happy it does resolve. I have some labetalol that I'll take if necessary, you know, if it seems to be persisting, but it typically resolves within 30 seconds. And that's fortunate for me. So I'm happy that I'm at that level, and I'm thankful to hear everyone else's story. It helps me to understand, again, what's coming, but maybe not. Maybe I could be optimistic and hope that it remains at this level for years to come.
Thank you, Tim, for sharing that. And I hope that that seeing that the outcomes of, you know, for sure, these panelists, your mom and Tom and Karen, you know, give you hope for the future, and as well as audience members who are also, you know, living with this illness. So what I wanted to do is, I definitely want to give us some time to have some question and answers for both Dr. Maron, because there's a number of questions, as well as for the panelists, because again, I think we learned so much, obviously, from Dr. Maron, who is clearly an expert in this field, and also all of you are experts as well. So I'd like to thank you again for sharing everything that you have with the audience. Dr. Maron, a question that just kept coming up again and again and again is, what is the percentage of obstructive versus non-obstructive? And can the same genetic anomalies cause either one?
Yeah, great questions. In the answer to the first question is 70%, 70, of patients with HCM have the obstructive form, and 30% are non-obstructive. And when you've got the obstructive form, so you're in the 70% of obstructive patients, you know, those are patients that, if they have symptoms, are candidates for different treatments than the obstructive form. And that's why it's so important to get patients into the right group, because obviously different treatments for different groups, and some of those treatments for the obstructives are very, very powerful at making patients feel better. And of course, if you've got obstructive HCM and you've got symptoms, you've got many options for treatments, but one of them is not transplant. We never transplant a patient with obstructive HCM because the heart failure can be reversed with one or more of those other treatment options that are not available to the non-obstructive patient. And the second question, I think, was about the genetic mutations can cause either obstructive or non-obstructive. So for example, the same mutation can cause an obstructed form, but in a different family or a different patient, sometimes that can cause the non-obstructive form. It's actually, that's the way, so it's not intuitive, but that's actually the way it is, actually, that the mutation doesn't predict itself which form. The only way to determine that is not with the mutation, but by using the echocardiogram to determine obstructive versus non-obstructive.
So you hit upon this, and this Darlene spoke earlier in regards to, you know, an EKG for diagnosis of HCM. It's the echo that really is it, or is it others? If you could pick, there's a number of modalities, I imagine, for diagnosing, as Karen very nicely went through. But what would you say are the most important studies to diagnose?
Yeah, the workhorse in terms of a diagnosis, the one test that we rely almost always on to make a clinical diagnosis of HCM, obstructive or non-obstructive, the diagnosis based on the echocardiogram, the ultrasound of the heart, demonstrating that there is an increase in wall thickness of the left lower chamber that exceeds normal, and for which there's no other reason for that thickness to be in that patient. And so it's the echocardiogram showing us that increase in wall thickness that makes the diagnosis of HCM. And then the echo can go even further to help us to decide obstructive versus non-obstructive.
And do obstructive patients, after the procedures are done, do they ever get to a point where they also need a transplant?
Yeah, so that's right. So that's it's a good question and it's a good observation. Very rarely, a patient who has obstruction, who develops heart failure symptoms, gets a myectomy or alcohol ablation, can do much better for a long time, and then can start to develop heart failure as a non-obstructive patient at that point, and then would become a candidate for, if drugs aren't working enough, for heart transplant. So that does occur, but it's very uncommon.
Right. How are HCM transplant patients' outcomes different, or are they different from patients with dilated cardiomyopathy?
Yeah, I didn't get too much into this because I didn't want to. It's a little bit, it's a little complicated, but to make it simple, I think here's what I would say is a fair way of sort of answering that question. In the current era of transplant, the outcomes of patients that are transplanted for HCM, the long-term outcomes are as good or even maybe a little bit better than patients transplanted for other types of heart diseases, including dilated cardiomyopathy. Why is that? Probably because the HCM patients who get transplanted are generally a little bit younger in age and generally usually a little bit healthier than other patients transplanted with other heart diseases. And so for that reason, we believe the outcomes after transplant are as good or a little bit better for that reason.
That makes sense. Thank you. Two more questions I want to get at.
Sure.
One is the medication question, and one has to do with mechanical support, because you talked about the fact that for HCM patients, most times they are not eligible for something like an LVAD or some types of mechanical support. One of the questions from the audience had to do with the use of our Abiomed's Impella devices. Do they help HCM patients at any period, before transplant? Is there a time that an Impella might help a patient have a better quality of life or extend life, is the question.
Yeah, I think the answer there is that it could, in a certain individual patient, that's possible. So the answer really, the answer to that kind of question is really about individualization, okay? In HCM in particular, you really have to look at the individual patient and the individual patient's heart and the size of the heart and so forth, taking into consideration all those anatomic considerations before ultimately deciding if a patient could be a candidate for some of these devices that you're talking about, including LVAD. And we have put LVADs, left ventricular assist devices, in patients with HCM, because in that patient, for example, their left lower chamber was big enough to safely and effectively put an LVAD in. For most patients with HCM, that may not be the case, but there can be some that are. So in other words, the answer to this question is all those therapies are possible for a patient with HCM, but it really requires an individualization and working with that heart failure transplant team and surgeons to see if it's possible.
Great, thank you. One last question, and then so that we'll be on time. It has to do with the medication mavacamten. Mavacamten. Has that shown any promise insofar as slowing the progression of left atrial dilatation and subsequently AFib?
Yeah, so mavacamten, new drug, it's in a class called myosin inhibitors. So the drug decreases some of the interactions that are going on at that sarcomere level of the heart. And what the drug has been shown to do so far is by doing that, it can lower the pressures in the heart in those patients that have obstructive HCM. Okay, so it may be another drug option for symptomatic obstructive HCM. And when it does lower those pressures in those patients, in some of them, the left atrial size can decrease, but So that may also be an additional benefit. So what we don't know though is a lot of things, but one of the things we don't know is whether that is a long-term benefit or whether it's short-term, and whether the drug will have benefit in non-obstructive HCM patients. That's unclear right now. So there's a lot to learn about that new drug. It's not even FDA approved yet. And I think we're going to know a lot more about where it fits in and its potential advantages over many years here. But it's exciting that we've got an opportunity for a new drug.
Right. Well, thank you so much, Dr. Maron, as well as the panelists. This was amazingly informative, and appreciate all your work on this and all your time and effort in sharing your stories, your personal stories with us. I'm going to hand this back to Hamid to close us out.
Hello?
Hamid, you're on mute.
Thank you for that, Tom. So I just want to say thank you. Thank you, everyone, for your participation. Dr. Maron, so enlightening and informative. Just thank you. Having been a HCM patient myself, for at least I thought I am, I don't know, but we'll find out. So just wanted to close out with some available resources from Heart Brothers. We have a patient assistance request form. You can go to our website, fill one out, and we will evaluate and respond to them for if you're looking for some kind of assistance. We obviously have the Heart Brothers House. Again, you can go to our website and try to make a reservation for that house. It's a first come, first serve. There's 2 units available in Boston's Back Bay area. We have a patient support group. It's monthly, it's virtual. It's the second Thursday of every month at 6 o'clock. We have Team Heart Brothers. Those of us who are a member of the organization, you can reach out through us directly or through your hospital social workers. We're available if you want to talk with someone. If your loved one wants to talk with someone, want to talk with our spouses or our loved ones, so we can basically share our experiences and share our thoughts. And then we have books we love, Therapist Finder, and helpful websites, apps, and brochures. Those are all available at our heartbrothers.org website. And our next heart failure webinar is going to be the heart failure and heart transplant journey, the caregiver's perspective. It will be Thursday, May 19th. I encourage you all to attend. Promises to be an exciting and, again, very informative session from a totally different perspective for the people who take care of heart failure and transplant patients. The world through their eye and their prism. With that, here's how you can contact us, connect with us. And again, thank you all for your attendance and have a great and healthy week.